Osteoporosis is a skeletal disorder characterized by compromised bone strength, which predisposes to the development of fragility fractures. Bone strength is determined by both bone mass and bone quality. The diagnosis of osteoporosis is established by the presence of a true fragility fracture or, in patients who have never sustained a fragility fracture, by measuring bone mineral density (BMD), or using the FRAX risk assessment tool. What are fragility fractures? Fragility fractures are those that occur spontaneously or following minimal trauma, defined as falling from a standing height or less. Fractures of the vertebrae, hips, humerus, and distal radius Cole's fracture, are the most characteristic fragility fractures, but osteoporosis patients are prone to all types of fractures. Up to 40% of women and 20% of men develop one or more osteoporotic fractures during their lifetime. What are the complications of osteoporotic fragility fractures? Vertebral fractures cause loss of height, anterior kyphosis, dowager's hump, reduced pulmonary function, each. Fracture decreases forced vital capacity by 9%, and an increased mortality rate. Approximately 1/3 of all vertebral fractures are painful, but 2/3 are asymptomatic. Hip fractures are associated with permanent disability in nearly 50% of patients and with a 20% excess mortality rate compared with the age-matched non-fracture population. What factors contribute most to the risk of developing an osteoporotic fracture? Low BMD, twofold increased risk for every 1 standard deviation, T-score, decrease of BMD. Age, twofold increased risk for every decade of age greater than 60 years. Previous fragility fracture, 5-fold increased risk for a future fracture. Frequent falls. GC use. Pearl. An older person is more likely to suffer a fracture than a younger person with the exact same T-score. This pearl also applies to a patient treated with GCs compared with a person who is not. 5. How is the diagnosis of osteoporosis made? Osteoporosis can be diagnosed by any of 3 criteria: fragility fracture, low bone density, high FRAX risk score. 1. Fragility fracture criteria. The presence or history of a fragility fracture establishes a diagnosis of osteoporosis, regardless of the BMD T-score. 2. Bone densitometry criteria. BMD T-score below a diagnostic level at any site indicates the presence of osteoporosis in a patient aged greater than 50 years without fractures. The diagnostic T-score ranges are as follows. T-score is greater than or equal to -1 normal T-score between -1 and -2.5 osteopenia T-score is less than or equal to -2.5 osteoporosis. In a premenopausal woman or man aged less than 50 years, the diagnosis can be made based on a BMD-Z score of as less than or equal to -2.0 at the lowest skeletal site. 3. FRAX risk assessment criteria. A FRAX risk score 10-year greater than 3% for hip fracture or greater than 20% for major osteoporosis fractures can also be used to diagnose osteoporosis. How do you determine if a patient has had a previous vertebral fracture? Back pain or tenderness are helpful clues but may be absent since 2/3 of vertebral fractures are asymptomatic. Height loss of greater than 2 inches or dorsal kyphosis are highly suggestive clinical findings. Methods such as vertebral imaging with lateral spine films or dual energy X-ray absorptiometry, DXA, vertebral fracture assessment, are the most accurate ways to detect existing vertebral fractures. 7. How is BMD currently measured? DXA is the most accurate and widely used method in current practice. The radiation exposure is minimal, with only 1 to 3 USV, site compared with 50 to 100 USV for one chest radiograph. BMD can also be measured by computed tomography, 50 USV, and ultrasound, no radiation. Central densitometry (DXA) measurements. Spine and hip are the best predictors of fracture risk and have the best precision for longitudinal monitoring. Peripheral densitometry measurements, heel, radius, hands, are more widely available and less expensive, but are less accurate. 8. What are the currently accepted indications for BMD measurement? Age greater than 65 years, women, ages greater than or equal to 70, men. Estrogen deficiency +1 risk factor for osteoporosis. Vertebral deformity, fracture, or osteopenia by X-ray. Primary hyperparathyroidism. GC therapy is greater than or equal to 5 mg per day of prednisone for is greater than or equal to 3 months. Monitoring the response to a Food and Drug Administration approved osteoporosis medication. How do you read a bone densitometry report? T-score. The number of standard deviations, SD, the patient is below or above the mean value for young, 30 years, normal subjects, peak bone mass. The T-score is a good predictor of the fracture risk. Z-score. The number of SD the patient is below or above the mean value for age-matched normal subjects. The Z-score indicates whether or not the BMD is appropriate for age. A low Z-score is predictive of an underlying secondary cause other than age or menopause. Absolute BMD. The actual BMD expressed in gram per square centimeter. This is the value that should be used to calculate changes in BMD during longitudinal follow-up. What estimates of bone loss and fracture risk can be made from a patient's bone mineral density measurement by DXA? T-score % bone loss of fracture risk. -1. 12. 2 times. -2. 24. 4 times. -3. 36. 8 times. -4. 48. 16 times. Note that one has to lose 30% of BMD to see osteopenia on a routine radiograph. This degree of loss suggests a T-score of -2.5. Pearl. An older patient is more likely to fracture than a younger individual with the exact same T-score. How do you use FRAX risk assessment tool? The Fracture Risk Assessment (FRAX) tool is a free computer-based program developed by the World Health Organization (WHO). It uses clinical risk factors with or without femoral neck BMD to provide a 10-year absolute risk estimate for developing a hip or another major osteoporotic (MOP) wrist, proximal humerus, etc. fracture. It is recommended to be used for making treatment decisions in drug-naive patients aged greater than 40. What is a trabecular bone score (TBS), and how is it used? TBS is a newer technique developed to evaluate bone quality. TBS uses data from existing DXA lumbar spine images to produce a gray-level textural index that correlates well with fracture risk in postmenopausal women and in men aged greater than 50 years. It can be used in conjunction with DXA to assist with decisions about initiation of osteoporosis therapy. TBS can also be entered into the FRAX risk assessment tool. It should not be used alone as it is not validated as a tool for monitoring therapy. TBS is particularly useful in disorders for which DXA alone significantly underestimates fracture risk, such as GIOP and diabetes mellitus. What are the major risk factors for the development of osteoporosis? **** non-modifiable. Advanced age, race, Caucasian, Asian, female sex. Early menopause. Slender build, less than 127 pounds. Positive family history, HIP FX. Asterisk 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 modifiable. Low calcium intake, low vitamin D intake, estrogen deficiency. Sedentary lifestyle, cigarette smoking, alcohol excess, greater than 2 drinks per day, caffeine excess, greater than 2 servings per day. What other conditions must be considered as causes of low BMD? Osteomalacia celiac disease. Osteogenesis imperfecta inflammatory bowel disease. Ehlers-Danlos syndrome gastrectomy, bowel bypass surgery hyperparathyroidism primary biliary cirrhosis. Hyperthyroidism multiple myeloma hyperprolactinemia rheumatoid arthritis, systemic lupus erythematosus. Alcoholism ankylosing spondylitis hypogonadism renal failure Cushing's syndrome renal tubular acidosis eating, exercise disorders idiopathic hypercholesteruria. High-risk medications of systemic mastocytosis chronic hyponatremia. Outline a cost-effective evaluation to rule out other causes of low bone mass. Calcium, albumin, phosphorus, creatinine, CO2. Alkaline phosphatase. 25-hydroxy-O, vitamin D. Testosterone, men. Thyroid-stimulating hormone, if clinically hyperthyroid. Celiac disease antibody testing, if Caucasian with symptoms or low 2,5-OH vitamin D level. Urine, 24 hours, calcium, sodium, creatinine. Serum protein electrophoresis, if aged greater than 50 years with abnormal complete blood count.